Good morning, everybody. It's Friday. I wanted to take some time since we had some difficulty with our fireside chat this week to just kind of record a review here of chapters 4, 5, and 6. I've had some folks send me some good questions. I've had some folks call and ask me some good questions, and I've told people that I always apologize to my EMT classes for the first 6 chapters. Very important information, but kind of boring. I get it. You kind of got to make the best of what it is and what you're doing and those type things. But like I say, I want to take some time and go through some review material with you. But before we do that, you should be able to see your student screen here. I want to show you a couple things I've started doing. If you come in here to, this is our home screen, of course. If you come down here to your modules, you'll notice today that in module 2, week 2, I have started uploading some things here, body system cards, body system interaction chart. I told you I've got all kinds of review stuff that I've collected over the years. And a lot of it's review for your test, and a lot of it's just good stuff to help make you a good, solid EMT and provider and help you keep up with what's going on. So I always watch back for those, and I will do my best to try to always let you know when we are, that I put something up there or something to that effect so that you'll know. But let's go back and look, and everybody keeps asking me about this confounded chapter 1 of the week 1 case study. We have a corrupt file in that. They're trying to correct for me. Everybody just forget about that and move on, and we will circle back to that later on during some of our review time. So everybody should solidly be into week 2 by now. Chapters 4, 5, and 6. Chapter 4, communication documentation. Chapter 5, medical terminology. Chapter 6, the human body and anatomy. So I've kind of prepared some slides and cut out some material that came from your slides, as well as some things that I've added. I just want to shoot through a little bit of a review with you. Looking at all this material, I've had some people call me and say, oh my goodness, I don't have an EMT background, or I've never took anatomy and physiology, or I'm not in a nursing program. What am I going to do with all this anatomy? Well, one of the reasons that this AAOS text and the Jones and Bartlett material is the only book I use, and I'll tell you why. You do need to read through chapter 6, and you do need to know the basics of anatomy, but don't get too in the weeds with it right now, because everything we go through from now on, for instance, here in a couple weeks when we do airway and respiratory, the very first thing that chapter and that part of the module is going to open up with is a review of the anatomy specific to the parts we're working with. So you'll get hit with that anatomy review all the way through. Now, on your own, for each body system we do, and each chief complaint we look at, and each type of information we look at for the patient, you do need to come back to this chapter 6 every once in a while and just kind of review the key anatomy pieces for that. But I'm going to show you some things I've put up for you here in a little bit. So again, I've told you from the beginning, I'm not going to go back through all the lectures in every chapter. I'm going to pick out the pieces that are most important and put up some slides here that I've kind of created to help us through that. Let's take a look here. Let me get where I need to be. Changing up here. You see here in this written communication and documentation section, I want to talk about one of the biggest areas that comes out of this particular area is written communication, documentation, and reporting off to other staff members. For instance, when you deliver a patient to a hospital, whether it's to the emergency room or whether you're transporting them to another floor or whether you're taking, wherever you're taking that patient to. Part of our continuum of care is to make sure we have adequately reported what's going on with that patient from the time we got them to the time we turn them over. Not always your responsibility if you're doing some sort of an interfacility transfer or something like that. Not always your responsibility to report what happened prior to your pickup. That should have happened in the communication between the facilities. But let's talk a little bit about why it is important. Rule number one, and don't ever forget what I'm about to tell you right now to keep you out of trouble with your employers and everybody else in the world. Your patient care is not complete until your PCR patient care report is finished and filed. Okay? What is a patient care report? Your pre-hospital report, your run report, your whatever you call them where you're working. It's a legal document. It records all the actions from dispatch to the completion of the call, times you were dispatched, when you were on scene, what you found, patient's information, billing it. It's got everything in it. All right, and it's our responsibility as providers to make sure that these are done right, done correctly, managed properly. There's two types of PCRs, written and electronic. Now, all of your PCRs are electronic now because it's what the United States requires. You say, well, Chris, we learned earlier on that the government don't dictate to EMS each individual state. That's correct. But if you want to bill Medicare and Medicaid, you will use electronic charting. That's where that comes from. So each state now requires electronic PCRs to be done. A written report, when you go into the emergency rooms, you'll hear the nurses say, did you leave me a hot sheet? Did you leave me a note sheet? Most providers have a sheet on their clipboard where they've written down their vital signs, what they had, so that they can go back and prepare this chart later on, the electronic chart. That's what they're talking about by a hot sheet or a written report or something like that. And you can just copy it and leave it with the staff, and that's fine. 6 functions of a PCR, and you may see this again. Continuity of care. It shows that you picked up a patient, you assessed a patient, you cared for a patient, you documented what you saw, what you heard, what you smelled, what you did, and then you rolled that right into the report that you gave the hospital. It shows no break in care of that patient from the time we pick them up until the time we deliver them where they need to go. It's a legal document. Patient accuses you of not doing something or of doing something or states something wasn't what it is, or a nurse says something didn't happen. There's your written documentation of what happened. PCRs can be used for education. I frequently pull reports of how many chest pain calls were in, how many chest pain calls got nitroglycerin, how many chest pain calls went to one hospital. You can use these documents to develop education based on parts that you've pulled from where your staff has done certain treatments or not done certain treatments, whatever the case may be. You need to always be cognizant it can be used for education. Administrative information, billing, demographics, those type things. Essential research record. You'll hear the term NEMESIS, National Emergency Medical Services Incident System. When we submit these legal documents, they're reported to the state, and the state has to pull out from NEMESIS and send them to all sorts of places where you can extrapolate and gain all kinds of information from the types of patients to the age groups of patients, and these are things that, and that's how new standard EMS things come about. That's how courses like this are developed. That's where fresh information comes from, is the research from a lot of patient care records sometimes. Evaluation, continuing quality improvement, that kind of ties back to the education. I know here at Thorne, a lot of times we will pick a monthly topic. Maybe this month we're going to pull chest injuries. We'll pull all the charts written and filed from chest injuries. We'll read through those where treatment's done properly, where the time's done properly, did certain pieces of equipment get used, and that helps us go back and look to make sure that people are doing what they're supposed to do, how they're supposed to do it. Patient care reports need to contain certain information all the time. Your chief complaint, level of conscious or mental status, vital signs, initial assessment, patient demographics, all these things flow right into what is administrative information. That goes to things such as how was the incident reported, when were you notified, when did you arrive, how long were you on scene, all these type things become statistical errors. What the patient care that was done by the time you were transferred, any of those type things. This is not what we use where we're at. This is just an example to show you all of your patient care charting systems now have drop-down menus. So you're going to fill out these drop-down menus, and it's going to do quite a bit from it toward getting that patient care report done for you in the way of you'll go through these selection boxes and pick what you need. Okay? Those are your check boxes. Then you have your narrative section. Keep in mind too, and you'll find this out, and the last people you want on your hind-end are billing people. Medicare and Medicaid and most insurance companies cut that chart down, and the only thing they care about is the name, address, birth date, social security number, and narrative for that chart. All right, so when you write a narrative, let's look at what the key parts of it are. Now, I'm not going to get into examples of narratives right now because I want you to start thinking your way through those and developing your way through those. And after we finish patient assessment, remember, you'll be able to start doing your ride time. And each of those patient encounters is set up where you'll have to write a narrative for them. Then I can go back and work with each one of you on how you clean up your narratives, how you make your narratives better, and things of that nature. But narrative section needs to be complete, concise, spelled correctly. Yes, inpatient care, grammar, and spelling counts. The last thing you want to ever do is write a narrative and then be on a witness stand and have a lawyer say, well, if you can't even spell this correctly, how do we know you're able to treat the patient? And they will do that. Elements or time of events. What were your assessment findings? Was the patient conscious, alert, oriented? What did you find? And we'll go through later on as we go through the course, we'll go through different types and different methods for how to chart. Excuse me. Emergency medical care provided. What did you do? What treatments did you provide? Changes in the patient after the treatment. Changes for the good, changes for the bad, no changes at all. These things need to be documented. Observations at the scene. For instance, if you were in a car wreck, those doctors don't get to see the car. So you need to put in your narrative that the steering wheel was displaced 2 feet, the car was on fire, whatever the case may be. Remember, you are the eyes, ears, and hands of that position in the scene. So you need to report back to those guys and gals in the ER with good information. Final patient disposition. How did you drop your patient off? Where did you put your patient? What condition was the patient in when you dropped him off as compared to when you picked him up? Where did you leave their belongings? If they refused any care you offered throughout the transport, that needs to be documented. Staff member, who you gave the patient to, who you reported off to. You don't have to have their whole name. Like I'll do, when I document this, I'll say patient left in bed 4, a VR report given to Tom, RN. That's good enough for that. Includes significant negative findings and important observations about the scene. All right? What do we mean by what's a negative finding? All right? Anything you did not find, it should be there. Don't make any judgment about the patient. Do not document that the patient was drunk. You can document that the patient stated they had 13 beers, or patients you can document that the patient appeared to be, or things of that nature, but you cannot out and out say somebody is intoxicated, things of that nature. Don't put radio codes and only use standard abbreviations in your charting. We're typing charts now, so abbreviations should be going away more and more all the time. Remember, these are confidential HIPAA-protected documents, and we will drill into HIPAA hard here later on. So if you make a reporting error, on the chart, right here is a copy of the hot sheet that you would turn in or leave at the hospital. Strike through it, put your initials and time there, and move on. Falsification of records is criminal offense, and I'll leave that right there. If you put something in an electronic chart incorrectly, they all have a section where you can put an addendum in it to correct the error you made. Documenting refusals. One of the biggest reasons ambulance companies find themselves in litigation or in court is people who refuse care and something goes wrong. You can't force people to go to the hospital, but our job is to try to get them to go if in fact we believe they need to go. You need to document throughout your chart and in your narrative your assessment of the patient, why you think they need to go, what you advise them. You need to make sure that if they're signing a refusal for care or waiver for care, that it's based on informed consent. You've explained to them what I'm not a doctor, but I believe these things could happen. You need to sign it, have them sign it, and have a family member, police officer, or bystander not associated with your crew sign that if possible. Make sure your PCRs are complete, and it's a good idea, and most places have a policy we do that you shouldn't leave work with your charts not complete. Moving from charts to special reporting situations, I want to make sure that everybody understands that across most of the 50 states, remember, when we get finished with this class, all of you guys will gain South Carolina certification, but it's also a national registry-based course, so I've got to tell you about the whole country too. Most places have a requirement that you report the following things: gunshot wounds and or criminal type things, dog bites, infectious diseases, suspected physical or sexual abuse of especially minors and elderly, and any mass casualty incident, which obviously that gets reported typically through dispatch. But now, that don't mean you call the police and say, hey, such and such has AIDS. That means you report to the hospital, or if you don't know who to report to, typically you will call your on-duty supervisors or your compliance officer, whomever, or you could pull the nurse aside and say, hey, I think, this child has been the victim of, and this is why I think. All right, you can be held responsible for not reporting something you believe to be the case in something like that. Medical control. We advised, I learned earlier on in our previous chapters, that medical control comes in two forms. Online medical control, meaning you are talking to them on the radio, on the phone, in person, whatever, you are dealing with the physician at the time, versus offline medical control, which is your protocol to do something. So we're going to talk a little bit about online. So communicating with medical control, why do we do that? Number one, we need an opinion. We need their help. We need to ask their permission to do something because our protocol says we need to ask them, or it might be a little bit off for something that is a little bit different than what we need to do. Medical control can be at your receiving hospital. Sometimes it can be at the referring hospital if you're transporting between two hospitals. So you have some different options when you contact medical control. When you get to where you're going to work, your company policy will dictate that. Contacting medical control, you need to notify the hospital of the incoming patient. You're going to give them a report. You don't need to give them a 30-minute report. I'm transplanting to your facility with a 52-year-old male patient complaining of chest pain. Chest pain onset 2 hours ago, unrelieved by anything. Patient vitals are, give them the vital signs. Patient presents, give them a brief assessment. We've administered nitroglycerin, have patient on oxygen. Do you have any further orders? Or if you have a question for that doctor, would you like for us to? All right, that gives the hospital notification that you're coming. The doctor can get ready for what you're bringing in, and he can give you any orders that he may want you to complete. Giving your patient report or handoff at the hospital or when you're on the way to the hospital is where it starts. The fact that give me your unit, always give me your unit, Medical 1, BLS unit. Let them know if you're ALS or BLS, because that immediately sets up their mindset for what you should have had done, what you can do, and what the doctor may be able to tell you going forward. These doctors and nurses in most of our ERs have a basic working knowledge of what we as EMS providers can do based on our certification levels across the state. So just keep that in mind. It's not something that you have to tell them or explain to them. All right, let the receiving facility know how far out you are. Patient's age, gender, chief complaint, just like we talked about a second ago. Brief history of the problem. Brief physical findings and a brief summary. If they want more detail, 9 times out of 10 they'll ask you for it. All right. If you've done some kind of treatment, how did the patient respond to that treatment? Role of medical control, again, offline, online. They may tell you to administer something, to withhold something. They want you, don't come here because this patient needs to go here for a certain reason instead. All these type things is what comes out of contacting and staying in touch with your medical command or medical control. Most places you're talking to a physician, but a lot of times a nurse, she'll give the report, she'll turn around and talk to the physician, give it back. If that is, you can do that. I mean, that's fine, it's up to them. You can call them on the phone, call them on the radio. If those are down, you can always go through your dispatch center. Make sure you provide them enough information to help you make the decisions that you need to do. Now, if a doctor gives you an order that doesn't make sense to you, don't blindly follow it. Always report it back. Medical 1 copies, you want me to administer 722 nitroglycerin tablets. Doc, is that not an awful lot? You can do that, That's a joke. Don't ever administer 741 nitroglycerin tablets. That would be, but even if the order is correct, always repeat it back to the physician. That's a closed loop. He told you, you received, then you gave it back to him. So it cuts way down on mistakes. Moving on to the next chapter of medical terminology. Guys, medical terminology, you just got to start in there and get familiar with it, with your prefixes, your root words. You go through all that. We're going to be using them over and over and over through this course. So don't get freaked out or scared by them. Just start trying to learn them. But one place you do have to start memorizing are the following few things I'm going to go through with you now. Directional terms, movements, and positions. Right and left. Obviously, everybody in here, I hope, knows right and left. Superior and inferior. Superior toward the head. Inferior toward the feet. We just talked about calling into the hospital. You can use these terms. Medical terminology is not to make us sound really smart or other people feel really dumb. It's so that there's some specificity when we tell somebody something. It's a term that relates to a particular area, place, so that's why we use it. Lateral or medial. Medial toward the center of the body. Lateral away from the center. Proximal, closer to. The little finger is distal. Away from your little finger is distal to your shoulder. So proximal and distal gives you a starting point and a finishing point to talk about the location of something. A patient was stabbed 6 inches distal to the elbow. That lets the doctor in his mind kind of draw a picture of what you're talking about. Superficial, on top of the skin, versus deep, down deep into it. Ventral and dorsal. The only way I could ever remember ventral and dorsal to this day is to think about the dorsal fin on a fish. That's basically a way to say front and back. Palmar and plantar, they're out there. They're not used that much anymore. Apex means where it comes to a point. The number one place you'll talk about apex is talking about the tip end of the apex point of the heart, and there'll be a few others that we'll address when we get there. So go back and go through these directional terms in your book periodically and kind of know how to use them and where they relate to. We said superior and inferior, the head versus the feet. Lateral, we just talked about that, toward the center or away from the center. Proximal and distal, we use a whole lot. Superficial and deep, we use these some. We're thinking about burns, chemical burns, people who have injected themselves with something. These will come up from time to time. Again, ventral and dorsal. Dorsal means the spine or the back part of the body. Palmar and plantar, you're thinking about the hands and feet there versus the apex is the tip. Here's some others. Movement, flexion, the bending of the joint, extension to straighten, abduction and adduction. Add to increase or move toward the midline, abduction to take away from. These are ones that you'll need to be very familiar with. Bilateral, both sides of the body. Unilateral, only one. Those come in, for instance, stroke. Patient has unilateral weakness. You can use these in your reports and documentation. Prone and supine, we will use a lot. It's how you're laying, face down and face up. Fowler position, you're sitting. We document that on almost every patient. Patient was placed on a cot in a Fowler's, semi-Fowler's, or full Fowler's position, meaning they were sitting all the way up or reclined at a certain amount. Planes of the body we will use. Sagittal plane, know these planes here. Transverse if he cuts you in half to waist. Sagittal if we cut you in half into two sides, left and right, and frontal is if we go across and cross-section you between your shoulders from front to back. We will see those come up a lot, especially if you're doing interfacility transports and you're reading through the chart. They typically use those planes a whole lot. I put this in here because we're going to be coming up with it in our next few chapters, airway. Do not make the mistake of thinking that the airway stops right here at the Adam's apple. The airway starts at the nose and mouth and goes to the tip of the lungs, the apex of the lung, or near your diaphragm, all right? This is one of the few systems where you will need to know each part of that. Divided into the upper airway, at these particular parts, into the lower airway from here. All right, so you need to know those. All right, so I told you, Chris gives you plenty of stuff to study. All right, so here are some things for each body system: the integumentary system, the skeletal system, the digestive system, and what you need to know quick. Notes. Don't worry about trying to take them out of this little video, because I'll show you a trick here in a minute. All right, you got your circulatory, nervous, respiratory system, endocrine system. All that stuff is already on here for you. You can cut them up using the splice cards, whatever you want to do. Got your lymphatic system, reproductive system, immune. Goes through all your different circulatory systems. I tell you, I'll give you more stuff than you'll want by the time this course is over to help you. Here's a good one, human body systems, digestive function, where it's at, major organs, and what else does it interact with. This is just some good quick notes to help you memorize these things. All right, so where can I find these? I told you earlier, back here, here's your flashcards for body systems. All right, they'll come up right here. You can download them, you can print them out, do whatever you want to with them. If they come up upside down, just use the little wheel up here to spin them around and get them ready to go there. So that's kind of the review of the important things for this week. I'll show you the other one there. Whoops, one more. Let's go back again. Wait a minute, and I'll get where I want to be. You come to the modules. They're on week 2. The other one is body system interactions. I'll put this video there as well as I'll put it in your email. So anytime I do little video clips or something, I'm going to start seeing me just inundate this thing with study things or real quick video and, hey, I found this today. You might want to look at it. So that's all I have for you in critical review. Email me or whatever questions you may have, and I'll reach back out to you and we'll get those done. If not, Happy studying, and I'll see you online.